Nah. Hi, Assalamualaikum, and thank you for joining my online presentation for this evening. And my name is Sharin Amri, and I'm a student for Bachelor of Medical Imaging NSSI 3. And my topic is about coronary artery disease or CAD. And if you have anything to ask, kindly ask during our Q&A session at the end of my presentation. For my presentation, I will go through one by one, starting from the introduction, and then after that, we will go through regarding the etiology and also sign and symptoms for coronary artery disease. And then we go through to the complication for CAD. And after that, I will explain regarding the imaging modalities for CAD and also the imaging or radiographic experience for CAD. And after that, I will explain regarding the treatment and also the prognosis for CAD. And lastly, is about a conclusion. So for the introduction, first we need to know what is coronary artery disease. So CAD is a common heart condition that involves atherosclerotic blood buildup in the vessel of human. And CAD, also known as ischemic heart disease, is the most deadly disease in the world. And it is about 51% of all cardiovascular cases is caused by the CAD. And according to the Department of Statistics Malaysia, ischemic heart disease continues to be the leading cause of mortality, counting nearly about 17% of the 109,155 deaths that were medically verified in 2020. So, pathophysiology of CAD, actually this process is caused by the accumulation of lipid deposit and also the endothelial cell dysfunction, macrophage induction, and also changes in smooth muscle cell. And blood buildup in the wall of the artery that supply blood to the heart will narrowing the arteries, and this process is called atherosclerosis. So atherosclerosis causing a major blood vessel that supply the heart struggle to send enough blood, oxygen, and also nutrients to the heart of muscle, and this will result in reducing the blood flow to the heart and can cause chest pain or angina and also SOB, while the complete blockage of the blood flow can cause a heart attack. Okay, now I will explain regarding the sign and symptom of COD. First, we go through to the sign of CAD that can manifest in various ways. For instance, first we have a heart arrhythmias, which means regular heart rhythm or abnormal heartbeats. And then we have heart palpitation, which is a sensation of rapid fluttering and also pounding heartbeat. And then we have clammy, sudden cold sweat or often accompanied by feeling of coldness. And then SOB, which is a difficulty of breathing and also feeling unable to get enough air. And then the symptom of COD, which is that might be suffered by the patient, is a chest pain or discomfort, or we call it as angina. Patient also suffer of weakness, fatigue, which is a feeling of constant exhaustion or tired, nausea, dizziness, or we call it feeling faint or unsteady or unstable, and also especially for women, sometimes they will feel pain and at the neck or jaw. For complication of CAD, if CAD is worsening, normally patient will suffer two conditions, which is heart failure and also heart attack. For heart failure, normally after affect the right half of the heart, this will cause edema to the patient, which is a swelling in the leg. Normally, blood build up in the vein that would normally transport blood from the organ and also tissue back to the heart. So the increased pressure inside the vein can push fluid out of the vein into surrounding tissue. So if this cannot occur, then patient will suffer edema or swelling in the leg. And then if the heart failure effect at the left side, this may cause shortness of breath or SOB, because normally blood will build up in the blood vessel that carry blood away from the lung. And after that, The other complication, which is a heart attack. It is occur when coronary artery become completely blocked. The blockage stops part of the heart muscle from getting enough oxygen and also become life-threatening. So heart attack can be divided into two, which is STMI, ST segment elevation myocardial infarction, and also non-STMI. Okay, now I will go through regarding the underlying factor that affect for coronary artery disease. First, we have a high cholesterol level. Elevated level of LDL cholesterol or bad cholesterol can lead to the plaque buildup in the arteries, and then hypertension, which is a high blood pressure. Also smoking, that tobacco smoke damage the blood vessel and increase the risk of atherosclerosis. The other one is DM or diabetic, and people with diabetes have a higher risk of developing CAD due to the elevated blood sugar level that can damage blood level. The other, and next we have being overweight or obese and leading a sedentary lifestyle are also risk factor for CAD. Family history and genetic, and also unhealthy diet. This is a diet high in saturated and trans fat as well as excessive salt intake can contribute to the development of CAD. And also age and gender, which is the risk of CAD increase with age, and men are generally at higher risk than menopause women. So there are several imaging modalities that help in assessing the structure and function of the heart and blood vessel. First, we have conventional radiograph or chest X-ray, and then cardiac CT angiogram. After that, we have a cardiac CT angiogram, and then also an invasive cardiac angiography, which is normal angiography. Okay, first I will explain regarding the conventional radiograph or chest X-ray. There are several advantages. First, we have a fast and easy because it is fast and easy to request, and also a baseline for early sign of CAD, and also more cost effective, and also it shows signs suggestive of CAD complication. We talk about the arch of aorta clarification. Later I will show about the image appearance regarding this point. And then it also acts as a preliminary screening tool for CAD and also as monitoring tools for CAD. And it also have disadvantages. First, it is low sensitivity and also low specificity. Also, inability to assess blood flow due to the non-contrast use. Inability to visualize coronary artery, and it also it is basic information, so it needs either modality to assist. So this is an image appearance of a conventional chest X-ray. You can see at the arrow, it is an AAC or calling as aortic arch clarification. It can be seen on a chest X-ray and accurately indicate the amount of the calcified change throughout the aorta. So according to the study in China, AAC, aortic arch clarification, severity is divided into 4 grades. First, we have a grade 0, which is a no visible calcification, and in grade 1, it is a small spot of calcification or a single thin. And then we have a grade 2, one or more areas of deep calcification, and then grade 3, circular calcification at the aortic node. Okay, now I will explain regarding the cardiac MRA. First, the advantages is no radiation exposure and non-invasive. Also, a soft tissue differentiation, which is MRA, offer excellent soft tissue contrast, allowing for better differentiation between healthy and diseased tissue. It also suitable for patients with CKD, chronic kidney disease, and also contrast allergic. After that, it also have high resolution and detailing image. This provide high resolution of the heart and also the blood vessel, and allowing for detailed visualization of the coronary arteries and detecting any abnormalities or blockage. So there are several disadvantages for cardiac MRA. First, the heart is constant motion and capturing clear image can be challenging, so motion artifact can affect image quality, potentially leading to inaccurate interpretation or difficulty in visualizing specific areas. Other than that, cardiac MRA also have a low specificity and also low spatial resolution. It also limited expertise and availability because MRA image requires specialized training expertise, and also not all medical facilities might have access to professional experience. And the other one is the longer scan time, and as we know, MRA typically require longer acquisition time, which can be problematic for patients who struggle to remain still for extended period. So this is some image experience for the cardiac MRA. First, we can see the 3D volume render in CMRA for mid left anterior descending. And then at the red arrow, you can see show occluded of the left circumflex artery of coronary artery in a 3D recurve MPR format of a T1 method of CMRA. And then the same patient go to the invasive coronary angiography, and it is confirmed that patient is fully occluded. And the second one is we can see there is an obstructive lesion nearly higher than 50% in the left anterior descending artery in the T2 method of CMRA. And also same patient go to the invasive angiography and get the same result. Show is that MRA showing a better visualization. And yeah. Okay, now I will explain regarding the advantages of the cardiac CT angiogram. First, it is non-invasive, which is doesn't require the insertion of catheter into the blood vessel or artery. And the second one, it has a high sensitivity and also accuracy to detect significant blockage in the coronary arteries. Also, cardiac CT angiogram have a versatility software updated, because nowadays there is a lot of new software such as calcium score, FFR, stress CT, and etc. And the last one is efficiency and speed, which is allow fast diagnosis and also easier to make decision or to refer other modalities such as invasive angiography. For disadvantages, cardiac CT angiogram is a high radiation exposure, so it is best for individual with repeated scan or those who has a sensitivity to radiation. And then also some individual might be allergic to the contrast material or have any problem. And it also have a false positive and also false negative. And lastly is high cost and limited expertise, because not all centers have these modalities and expertise to diagnose those images. So as we can see, this image appearance of the coronary CT angiography. First, we can see the CCTA image with calcium scoring reconstruction. First, we can see the RCA, which is the right common artery. The calcium score showing visualization of plaque buildup in the RCA, and then also in the LAD, and also in the left circumflex. And then study in Europe shows that stenosis is divided into phase 6, and important aspect of CCTA when reporting the severity of stenosis. First, it is normal, which means absence of plaque, and then below 25%, which is a minimal stenosis, and then we have mild, the plaque 25% to 49% of stenosis. We have a moderate, which is a 50 to the 69. And then severe, which is 70 to 99% of stenosis. And then the last one is the occluded, which is a fully stenosis, fully occlusion of the artery. Okay, now we have an image appearance, also well-known appearance of the CCTA for the CAD, which is a napkin ring sign. So first we have a positive modeling, you can see in the image. And then the low attenuation plaque, which means that radiation can be passed into the plaque. And then we have a Spotify calcification, and also we have a napkin ring sign, as we can see in the red arrow. And then there's one image, we can see the representative images of the napkin ring sign assessed by the coronary tomography angiography, CCTA, and a critical stenotic lesion, yellow arrow, you can see here, was shown in the mid portion of the right RCA in the curve MPR and stress reconstruction A and B. So a cross-sectional image perpendicular to the vessel movement C and D show an outer circumferential high attenuation area, right arrow, which is circle right, and a central low attenuation core. And L indicate the lumen, which is the circle one. Okay, now I will explain regarding the cardiac angiography. First, the advantages is a direct visualization, allow immediate intervention if necessary, and also it has a high sensitivity and specificity. It also has a high resolution and detailing image. And for cardiac angiography is a gold standard for visualization and assessing the CAD. There are several disadvantages for angiography, which is an invasive procedure, discomfort and recovery time. It also has a high risk for complication, which is a bleeding and mortality, and also require high radiation exposure. Okay, this is some image appearance of the invasive coronary angiography. First, we can see at the LAD, show 70 to 99% was confirmed with the stenosis. And also we have a significant coronary stenosis in the white arrow in the middle of the right RCA. And the last one, we can see the stenosis between 80 to 85% in the proximal and mid segment of the LAD, and also the 95% of stenosis in the proximal segment of the left circumflex artery. So the rationale is gold standard. Coronary angiography remains the gold standard imaging method for detection of CAD. For CCTA, it is a highly effective test that can be implemented as a first-line modality, given its ability to provide anatomical and physiological information at the same time. Cardiac MRA, CMRA can still be benefited due to its contrast-free, does not using ionizing radiation, and was well tolerated by all patients, achieving high diagnostic accuracy for excluding significant disease in patients at low intermediate risk of CAD. And then chest X-ray, it might provide valuable information also as a detection in predicting CAD severity. And now I'll explain regarding the treatment and prognosis. There are two types, which is a medication and also revascularization. First, we go through the medication. We have a statin. The medication most commonly used to reduce low density lipoprotein LDL cholesterol are recommended first-line therapy for CAD. And we have a STMB inhibit the Niemann C1 like 1 and PC1L1 protein in the GI tract, thereby reducing cholesterol absorption via the diet and modestly reducing blood LDL cholesterol level. And then the last one, we have a PCSK9, which is the protein convertase subtilisin casein 9. This protein was found to be preferentially produced in the liver and secreted into the bloodstream, where it antagonizes cellular LDL receptor. Soon thereafter, inhibiting mutation in PCSK9 were observed to have the effect of reducing blood LDL cholesterol level. Next, I will explain regarding the treatment and prognosis, which is a revascularization. What is revascularization? It is the restoration of blood circulation of an organ or area achieved by unblocking obstructed or disrupted blood vessel or by surgically placement. So it has two types, which is percutaneous coronary intervention (PCI) and also coronary artery bypass grafting (CABG). So what is PCI? PCI is a non-surgical invasive procedure. Non-surgical, it is an invasive procedure with the goal of relieving the narrowing or occlusion of the coronary artery and blood supply to the ischemic tissue. There are a lot of methods in the PCI. We have atherectomy, brachytherapy, IVUS, which is intravascular ultrasound, and also shockwave lithotripsy. But the most common being ballooning the narrow segment and also deploy a stent to keep the artery open. After that, we have a CABG. This is taking blood vessel from another part of the body, usually the chest and also the leg or arm, and attaching it to the coronary artery above and below the narrow area of blockage. So this new blood vessel is known as a graft. So this is a diagram show the treatment and process of vascularization. We have a two type, like I said just now, PCI and CAG. So for the diagnosis, it can be divided into 4 symptoms, and which is first is invisible ischemia. For ischemia, normally the invasive treatment, which is restoring of coronary flow capability, and both PCI and CABG are recommended. And after the procedure, normally patient will have a symptomatic relief. And then after that, we have the acute ischemia, both chronic and also the acute ischemia. For this kind of symptom, normally we will go through with the refusion. So both PCI and CABG are recommended, and after the procedure, patient will normally restoring the cardiac function and also improving the survival. And last one, we have a symptom of function. And for normally we will go through with infarct prevention, and CABG is more recommended rather than PCI. And after procedure, normally patient would have a MACE prevention and also improving survival. So what is MACE? MACE is basically a recurrent or persistent angina pectoris. So the conclusion is modality like CCTA and also CMRA can widely benefit in order to diagnose SCAD. CCTA is considered a screening tool for ICA rather than replacement, owing to a poorer image quality because of lower spatial resolution and also temporal resolution, motion and blooming artifact, as well as the dependency on a low and stable heart rate for adequate image acquisition. So for cardiac MRA, it can be an alternative non-invasive method for diagnosis and assessment for COD due to its high sensitivity and also specificity. For conventional X-ray, it might provide a valuable information in predicting CAD severity, and as technology progresses, new approaches for assessing CAD blood flow appear to offer reliable and simple alternatives to the more invasive wire-based technique, and also they are now the gold standard for assessing the CAD. So this is my reference for my presentation, and that's all for me. Thank you for joining my online presentation, and yeah, if you have any question, kindly you can ask now lah. Yes, you can ask in English or Malay, both. Thank you so much. Yeah, we go through with the Q&A session.
So, ada soalan ke? Banyaknya nak tanya soalan. Yang nak tanya soalan tu boleh buka speaker.
Saya ada satu soalan.
Siapa ni Nama?
Husna.
Oh, okey. Husna. Aini Husna.
Saya nak tanya. Ultrasound, mesin ultrasound tu, boleh ke kita diagnose CAD? CAD. Boleh guna juga mesin ultrasound?
Ultrasound boleh guna untuk CAD ke tak?
Itu je lah. Terima kasih.
Normally kita untuk ultrasound, dia memang kita tak guna dia untuk apa nama tu? Kita tak guna dia untuk diagnose CAD, tapi kita ada guna dia untuk masa kita nak buat catheterization. So saya ada share tadi dalam slide tadi. Sekejap saya buka slide dulu. So masa kita nak catheterization tu, dia tergolong dalam ni lah, ultrasound ni, dia ada termasuk sekali dalam percutaneous coronary intervention ni. So masa kita nak buat ultrasound tu, kita namakan dia IVUS, which is mean intravascular ultrasound. Selalunya kita akan masukkan catheter melalui artery, and then ultrasound probe tu kita akan letak dekat tip dia punya catheter tu. So dia akan go through sama-sama. Catheter tu pergi, and then dia punya ultrasound probe pun akan ikut. So namanya IVUS. Saya tak pasti dekat Malaysia ada buat ke tak, tapi tengok dalam bacaan saya kat Europe memang ada buat lah. Okay. Ada soalan lain ke? Hani ada soalan, apa ni? Kisti Hani. Ada soalan ke nak tanya?
Tak ada soalan, tertelkan je.
Lagi ada soalan lain ke sebelum kita tamatkan ni? Tadi So kita tutup kita punya saya punya presentation ni dengan terima kasih banyak-banyak kerana join lah. Thank you so much for joining my presentation.